Hello and welcome to today's webinar, Fit for Duty, Identifying and Managing Cumulative Stress Disorder in Organizations, Yourself, and Others. My name is Jonathan Bassett, editor at EMS World, and we're happy to have everyone joining us today. We'd like to thank Distance CME for sponsoring today's presentation. A couple of quick housekeeping items before we begin. During the webinar, feel free to submit questions and comments for our speaker by using the question submission section on your screen. And at the end of the presentation, we'll try to answer as many of your questions as we can in the time allowed. And with that, we're happy to welcome today's guest. James Boomhauer has been involved in EMS throughout New England for 15 years. He's currently a critical care transport specialist paramedic with Boston MedFlight in Bedford, Massachusetts, a peer supporter for Echo Fast, and lead instructor for Distance CME's online continuing education programs. James, it's great to have you joining us today. We were hoping you could start out by describing cumulative stress disorder and talking a little bit about the importance of discussing its impact on EMS providers.
I sure can, sir. Thank you so much for having me here. I think it's important, as you said, to start with what cumulative stress disorder is and how it looks. And one of the first things that we should really talk about is the fact that, well, we're going to give all sorts of signs and symptoms and things to look out for. This really can present itself a number of different ways to different individuals in different circumstances. So this is really more of a broad stroke approach to this. My biggest goal here is to help all first responders recognize what cumulative stress disorder is, accept it, and then work to develop tools and support systems to reduce its impact on yourself and on your agency.
All right, James, and can you talk a little bit about what you hope to accomplish with today's presentation, especially why is this so important to you personally?
Absolutely. My goal here is to help reduce stigma. I think the more that we talk about something, the more mainstream it becomes, the less kind of monster in the closet it is, and take away kind of the demonization of this really faux pas idea of providers needing mental health resilience and needing awareness on their own mental health and well-being, and making that commonplace. It's important to me because outside of my own struggles with mental health and well-being throughout my 15-year EMS career, I've lost colleagues, friends to suicide. And I've seen not only the pain that those individuals went through before they took their own lives, I've seen the vicarious trauma as to what is that's done to individuals and agencies long after they've passed. And I truly feel that if we approach this like everything else we do in EMS with intent and conscious thought and a whole lot of work, that we can take away that stigma and hopefully give some guidance for individuals that feel as though they have no other options.
And we do hear a lot about PTSD, not so much about CSD, so it's good to have this information. You touched on your story a little bit. I was wondering if you could briefly share with us some more details about your story, and specifically what was the trigger that awoke in you to this problem.
I absolutely can. The tagline here that I put in this slide for as much a kind of shock factor as humanly possible was, I was totally fine until I woke up half drunk in a blood-covered flight suit. I think the biggest part of my story that I share with people is how okay I thought I was. I had a great support system. I was still working for a premier critical care transport team in Boston, Massachusetts. I'd done every EMS job over the sun. I had, a decades-long career before I got into flight medicine. I had people, I had friends, I had family, I had all of these things that I thought I needed. And it sounds so cliche, but I never thought that it would happen to me. I thought that I had all the right tools in place and everything was fine. And the trigger that we talk about here isn't a really bad call that I went on. Well, that certainly played a role in it. It was my response to that call and everything else in my life that was crazy and chaotic. You know, the orientation was so stressful that I'd forgotten to pay rent, and my significant other and I were constantly fighting, and I didn't feel like I had that level of support. I wasn't eating well, I wasn't sleeping well, I was drinking to make sure I got some sleep, and this spiraled and went on and on and on until I found myself at an impasse of needing to get help immediately or doing something very drastic.
Okay, and I was wondering if PTSD was mentioned earlier, and you know that's very different than CSD. I was wondering if you could just define some of the main points and the main differences, and then we can move into kind of how to recognize signs in yourself and others.
Absolutely. I think that one of the biggest things that is helpful for people to understand is post-traumatic stress disorder is commonly defined with one principal event in place, right? There was this traumatic event, and then all of these things started to happen, right? Be it serving in a war zone, being on the civilian side, a really traumatic EMS event, fire event, things of the like. Whereas cumulative stress is how that chronic workload continues to bear down. And the biggest reason that I try to articulate the difference between the two is so many providers will say, I haven't had that call, or I haven't had this big traumatic event that is universally recognized as something that could benefit from support systems or could be a precursor to PTSD, where the same symptomology is found in people that might not have that big sentinel event, but have continued onslaughts of routinely stressful and complicated events, even if they don't reach that kind of predetermined level of tremendously traumatic event.
And obviously, so much of this is tied to prevention and you know, recognizing red flags before they manifest into something larger. Can you talk a little bit about the signs that there might be something wrong, either in yourself or a partner or a coworker? What are some of the telltale signs of CSD that we can look out for?
Absolutely. I think it's important at this stage of the game to point out that as pre-hospital medical professionals and as first responders as a whole, we are very, very good at recognizing signs in other people. And one of the big things that I would love to see come out of this that I haven't talked about yet is in this destigmatization of mental health awareness and resilience, is it okay to go up to a partner and say, hey, I see that you're going through a lot. I see that you're stressed. I see that you're very emotionally tired. What can we do to help you? I think the most infuriating thing is as we go through this list, we're going to see individuals and hear individuals say, oh my God, that was me 2 years ago, and my partner saw it and all my friends saw it, but nobody said anything. If we destigmatize this, then these signs are no different than any other signs and symptoms of anything else that we encounter on any given day. The list here is fairly straightforward. Emotionally exhausted and fragile. You know, when we look at our clinicians who come in and they're a stiff breeze away from either throwing a chair or breaking down into tears. Clinicians that feel overwhelmed, right? You walk through the door, your shift just started, and the onslaught comes, right? You have 3 calls waiting for you in the queue, your ambulance is half checked, and the check engine light's on, right? All hits you as soon as you walk through the door. Can you triage that and handle it and move through it, or does that instantly overwhelm you and take you over? We talk a lot in medicine about helplessness and hopelessness, and that's premier in first response for a number of reasons, right? We're limited in the tools and techniques and training that we have. You know, I can think of a million bad traumatic calls where if we were closer to an operating room, if we had a surgeon with us, maybe the outcome could be different. So we know that we're tied clinically to limitations, but when does that really start to make us feel hopeless? And when do we start to hear our partners or ourselves say, well, it wouldn't have made a difference anyway, or there's nothing we could do in a negative sense as far as why am I here and what am I actually doing? Depression is a bullet point that we could have a separate webinar about, right? When we talk about depression, we talk about a constellation of signs and symptoms that we see over time. When we look at substance abuse, I want to make very clear that this isn't just the individual who hits the bottle hard, right? When we talk about substance abuse, we also talk about the person who needs that glass of whiskey before they go to bed, right? I can tell you the day when I stopped wanting a glass of whiskey after work to I need a glass of whiskey to go to work. And we talk about that substance abuse, substance dependence kind of correlation there. Anxiety is pretty out front, right? We all know what that looks like. When we look at sleeping disorders, we know that work can make this more complicated, right? We rotate through days and nights. We get bad sleep while we're at work, all of these things. When do we notice that in the times that we can sleep, we're still not sleeping, or we're staring up at a wall, or we're doing all of this other stuff in the very few and far between times where we actually have the 8 hours to get some rest? Memory loss is really straightforward, right? When has that super smart clinician forgotten a protocol? Or when has that really on the ball individual forgotten a name or forgotten to get signatures or something? And I give you these real life examples because they're that tangible. You know, the provider who's never forgotten a protocol his entire life suddenly forgets a dose of aspirin, right? That may very well be a one-off, but if we look a little bit deeper, is that a sign of something a bit more in depth? Changes in our overall daily living, right? When are our clinicians coming in and not showering, not in clean uniforms, not brushing their teeth? You know, fundamental hygiene aspects are always very obvious and overt to see, but what about running out of gas? What about, you know, leaving cars unlocked, doors unlocked, stoves on, things that you do in the day-to-day without thinking about that suddenly become something cognizant that you have to focus on or notice that they aren't being done. And extreme emotions, I kind of tie that back into emotional exhaustion and fragility, right? We all know clinicians, and it could be ourselves, who get dispatched to something that we feel is not necessarily worth a paramedic or an EMT's time, right? Somebody calls with toe pain, or somebody calls with a sore tooth or something like that, and the provider loses their mind, right? Screaming, yelling, mad at dispatch, mad at everybody, rude to the patient, when we can normally maybe have those feelings but keep that well in check.
If some of these warning signs are not taken seriously, or they're ignored, or you know, there's a stigma attached and the provider doesn't seek help, and we'll talk about treatment and resources a bit down the line, but can you talk about some of the impacts of CSD to both providers, and also, you know, how is patient care impacted? What is the overall impact of CSD to the EMS industry?
Well, I think this, when we talk about this, I try to implore both the clinician and the supervisor and managerial side of the coin as well, as far as what's their buy-in into giving this any time, right? I can easily convince clinicians that we need to take care of one another. It's not always as easy to talk to agencies and programs about why they need to focus strongly on the mental and emotional health of their team. First things first is patient care, right? That's super simple. That emotionally exhausted, furious clinician simply is not going to provide good medicine. Certainly isn't going to provide the level of medicine that he or she would have provided in any other setting. And as we start to see CSD accumulate, for lack of a better term, right, and we see these signs and symptoms grow and expand and grow and expand, these clinicians are stopping coming to work, and they're utilizing sick time. As they continue to utilize their sick time, and as they continue to get more and more burned out and feel this stress continue to weigh on them, they'll eventually quit, which is a burden on any agency, right? You have to fill that space with overtime. You have to interact with other crew members. You have to hire new crew members, and it's a tremendous expense to do that. Now that we've forgotten about that employee, for lack of a better term, right? That employee's left, you know, maybe a couple of his friends check in on him every now and again, but now that that person has left our purview, the likelihood of self-harm outside of that reasonably protective setting gets higher. And that clinician harms themselves or commits suicide. Then you have the vicarious trauma that rolls to that agency. People mad that the agency didn't do more, clinicians that wanted to know how they could have helped, or why didn't they see it, or so on and so forth, and you watch that vicarious trauma snowball into the cumulative stress that the clinicians that are still there are feeling, and that affects their patient care, sick time, turnover, and this cycle just continues on and on.
Obviously, some very drastic implications here. So let's talk about stigmas. You mentioned the stigma a little bit earlier in the presentation. Are there stigmas associated with it? If so, why do you think that is? And how can a provider overcome that and seek help?
John, I think on its surface, it's because we are the helpers, and there has always been this implication that helpers don't need help, right? You can't simultaneously be the helper and need help at the same time. And in that function, we train our students and we advocate for our clinicians to be better, faster, and stronger than the patients that they're treating. And I don't mean socially or emotionally better, faster, stronger, but I mean logistically, right? I have to have the strength to pick you up and move you to the ambulance. I have to have the brain power to recall protocols, look at signs and symptoms, and practice good medicine as I move you from one facility to another, all while keeping this hierarchy of, I have to be better than my patients. I have to be this high functioning all the time. And there's this tremendous stigma that as soon as you start to ask for help, that you become less than. And you always see this metaphor utilized in the mental health circle of nobody would look at a broken wrist and say that someone's wrist wasn't broken, right? When we talk about depressions or symptomology of mental health, you can see a broken wrist, you can see that there's pain there that looks as though it's painful, and no one takes that away. And my argument is, in the EMS world, I know clinicians that have worked through broken wrists. I know people that have taken a hard fall on ice in an ambulance and continued with the call only to seek help after the patient was taken care of. And I think that that is just a perfect personification of the mental health stigma of as soon as I start to reach out or I start to get help, I will become less than. And then I can no longer hold my role as the protector and as the provider.
Which could lead someone to deny that there is even a problem. And do you, in your experience, do you find that denial is a problem? Are there providers that just don't want to believe that there's a problem, and why is acceptance of it so difficult for some people to achieve?
I put some text here on the bottom of this slide to talk about that. I think one of the biggest issues is we perceive getting help as weakness, right? Which is just no more than another stigma, right? We perceive the need to get help as a layer of weakness. And if we change that perception and say, you're not weak for getting help, you're stronger for making yourself a better clinician. This is no different, although this seems like a very sophomoric metaphor, this is no different than being bad at starting IVs and getting help at starting IVs, right? There's a facet of your healthcare and your ability to provide healthcare that is weak or needs help in the moment. So how can we give you that so you can become a better, stronger clinician? And as soon as I see, and I help in myself personally, as soon as I stop telling myself that I was weak, that I was pathetic, that I was nothing, and I have to go to therapy and nobody can know about it, and I was ultra mega secretive about it for a long time, as soon as I realized that what this was really doing was making me a better and stronger person to become more resilient and to make me stronger overall, all that did was improve my ability to be a better healthcare provider and a better person. So if we can help change that viewpoint of this is a sign of weakness and you're weak and need of assistance, and turn this back to this is just another way for you to grow and become a better and stronger person, which will be a better and stronger healthcare provider, we see that shift pretty clearly.
And you mentioned earlier that EMS providers are used to assuming the role of protector and takes care of problems. So obviously overcoming stigmas and overcoming denial means that you have to go from provider to patient. So talk a little bit about that. What is it? What's it like to go, from the provider role to the patient, and how do we take care basically of one of our own?
Absolutely, and I think that the term patient here is used very incredulously, right? And there's this concern that what you see on the slide is it, right? As soon as you say I need help, people in surgical masks are going to come hover over you, right? We know that's not the case, but it certainly feels that way, right? Because you're in certain aspects, you feel as though you're giving up your provider role, your protector role, and you're falling into a weaker role. And I think the biggest point of this to phase out is that's simply not true. When we talk about different tools and different approaches that you can take to ensure your own mental and physical health, seeking therapy is at the bottom, right? There are a number of things that we can do within an agency, within ourselves, quietly in a room somewhere to help foster and build this resilience and ensure that we're mentally sound. And working through this aspect of, oh, as soon as I become the quote unquote patient, it's going to be this big, long, dramatic thing, it is just another part of that stigma that we need to break down. The struggle with taking care of one of our own is just that, right? We're taking care of one of our own. It's in the terminology that we use. I truly feel that when providers see other providers in crisis, the scariest part of that is looking into a mirror, right? Joe's a really good paramedic. Jamie's a phenomenal paramedic, and here I am trying to help them. A, I may not have the training or the knowledge base to help them on the emotional side of the coin. And B, what if that's me, right? And it shows some vulnerability there, as here is someone who I once thought of as unbreakable, and now they're broken, quote unquote, right? And they're in need of my assistance. And that makes other people very nervous, because it starts to change that worldview of that role of the protector and of what that means, and that infallible and invincible person can be really hard for people to work through.
Okay, you've given us a lot of great information on how to recognize CSD, the impacts on the industry, and how to, overcome denial and assume the role of someone who does need help. We want to move a little bit into what to do about it, the tools and resources available. So, can you recommend some tools to help with CSD if you see some of these signs in yourself or others? How does one access the tools, and kind of talk a little bit about how people can help others in seeking help?
Absolutely. I think step one has got to be a willingness to ask yourself the question, right? I'm primarily now a critical care transport provider. 99% of my patient care is done in the helicopter EMS setting. And if anyone here has ever worked in helicopter EMS or interacts with their flight team, we have a checklist on checklist on checklist, right? I have a checklist to make sure that my checklists are in the right place. You can very much make that checklist your own personal mental health checklist. What's arguably the hardest part of this entire event is asking yourself if you're okay. Am I really okay? Right? Not am I telling other people that I'm okay, but am I actually okay? Am I eating? Am I sleeping? Am I staying hydrated? Where am I? And that very much ties into this aspect of self-care. And self-care has this interesting stigma that it has to be lavish and it has to be fancy. Self-care can simply be, I can't work on the PowerPoint today because I need sleep. I had a terrible overnight shift. I need to sleep. I need to tell someone no so I can get my own kind of foundational needs in check. Making sure that I'm eating, making sure that I'm staying hydrated. Admittedly, not the two easiest things in the world to do in the back of the ambulance, but if you're unable to do them in the ambulance, remember that, right? Make sure you know that. Something as simple as alternating an alcoholic beverage with a glass of water is tremendous in and of itself, right? Okay, you're going to go to the bar. Okay, you're going to be with your team, and there's a lot of benefit there, and kind of that debriefing with your team and de-stressing over a bad day. If you're going to have a drink, that's fine, but alternate with a glass of water, right? Make sure that we're keeping our own fundamental needs in check. So that self-care, self-check are really kind of this object that we can kind of bounce back and forth from. You can do self-care throughout your self-check. There are a number of different terminologies for what I'm showing you on this slide here. Yoga has a propensity for it. The armed forces utilizes it. Social workers utilize it as well. And I use the terminology here that I found the most frequently. It's called box breathing. It's simply the process of inhaling for 4 seconds, holding your breath while you're inhaled for 4 seconds, exhaling for 4 seconds, and then holding your breath at that exhale for 4 seconds. And you repeat that. This is simply a function of something to ground you, right? Everything is going on, work was crazy, and kids are yelling when I get home, this, that, and the other thing. If I taken a millisecond for myself to be able to start my own self-check, you can start right there. This has a number of other utilizations. I do this before I perform any stressful procedure. I do it before I go into stressful meetings. It's just an excellent way to ground you, remind you where you are, what's going on, lower your heart rate, and give you that space to perform that self-check and then the appropriate self-care.
Okay, and how about outside resources, more formal systems of support? Where can people go to seek help? What can they do to kind of get something started, and who can they reach out to?
So the list that I have here is a combination of some of the resources that I've used or I know of personally, and some resources that are very EMS-centric. The 911 Buddy Check, which is put together by a guy named Dan Mills, is a very well-reached resource. You can get a hold of him by phone, by Facebook message, Instagram, Twitter, you name it, and he has a way to come in contact with you. The National Suicide Hotline is a great resource that you can utilize either by call or by text. 7 Cups is an online chat platform where you instant message with a counselor. And I've heard a number of people use it with great success for those people who maybe aren't quite ready to make a phone call, maybe who aren't quite ready to reach out. There's a healthy level of anonymity there while still reaching out and getting some support. Up here in New England, there's the Uniformed Services Peer Council, which has a number of great resources, and one of the biggest things they're doing is they're working on creating a collaborative list of therapists, of social workers, of counselors that are EMS-centric and very pro-fire EMS and first response. One of the struggles with early stages of therapy, depending on how you go find a counselor, is they're a bit like mechanics. Right? You could go to a great counselor, but if they don't work well on your car, then you guys aren't going to mesh super well. So one of the plans here is to create a list that has those people already vetted out and has very EMS-centric and EMS and first response aware individuals ready to help you. Counseling overall is great. I know that there's stigma behind counseling, and I'm really working hard to break that. Counseling is nothing more than going to talk to another individual that has some level of degree or certification about what you need and how you can help. And it is a tremendously invaluable resource. The really good advice that I give with individuals that are willing to look into counseling is, like I said a moment ago, if you meet with a counselor and you don't jive, that's totally fine. That does not mean that counseling doesn't work for you. It just means that you need to find another counselor. I love the metaphor of the auto mechanic, because Bob could be the best auto mechanic in the world, but if he doesn't work on my broken down Chevy Cruze, then he doesn't work on my broken down Chevy Cruze. I just need to find someone who does. And it's really important to remember that it may take a little bit of work, but finding the right counselor can be tremendously helpful, along with chaplain services. There are a number of chaplain services throughout America that help specifically first responders. There's a whole separate branch that works specifically with helicopter EMS folks and critical care teams. For those that appreciate a more spiritual approach, there are always chaplain services available to you as well.
And just to mention to our audience, everyone listening today who's registered for the webinar will be receiving a post-presentation email with a list of these tips and resources that James has put together. So keep an eye out for that. We're going to be opening it up to questions from the audience soon. James, I just had one last question in closing. If you had one piece of overall advice to share with our audience, what would that be?
I certainly rue the term expert, although it's flattering. I think the best piece of advice to give is that it's okay to not be okay. That it is totally fine to need the help, to get the help. It is way better to get the help and be stronger than to convince yourself you don't need it and spiral down this path.
Okay, and with that, we are going to open up the floor. Again, if you have a question for James, feel free to enter it into the question submission box on your screen, and we will start with the first question. And we have a lot of questions coming in right now. Again, if you have a question for James, feel free to enter it into the question submission box, and we'll get to as many as we can in the remaining 30 minutes or so. James, the first question we had from a viewer touches on the topic of control. And they ask, don't you think that a lot of this is about control? Providers are supposed to be in control, and admitting that you need help is an admission that someone is not in control. And the stigma with that is that I will lose my job, I will be demoted, I'm a failure, and so forth. Can you talk about that?
Absolutely. I think you can kind of interchange both terms. I think you can say control is the stigma or the stigma is control, but the last half of this question here, you know, this individual's worry if they admit that they need help, they'll lose their job, they'll be demoted, they're a failure. I can speak to all of those individually as you talked about the guy going to therapy in your program. I absolutely think that in either way you look at it, the stigma does exist there, and control can very much be part of that because, as I mentioned in the presentation, we talk about, you know, what we perceive our healthcare providers to be as the protectors. And that protector leading to kind of a higher level or an upper echelon of individual. And I absolutely think that that's a big chunk of it, is that omission of control, which is why I said in the presentation that if we change our viewpoint and our thought process behind what it means to seek help, and that it's not an admission of failure, but more as a chance to grow and become a better provider, then you can turn that stigma of control on its head and say, I am taking control of this. I'm doing it to become a better, stronger healthcare provider and keep you in control the whole time.
Okay, we have a question here about managing a high-volume EMS system. Do you think that management of high-volume EMS systems also plays a part in stress and in the ability to manage stress?
I think it absolutely does. I've been fortunate. I've worked in a variety of systems throughout my career, and I'd like to think that the private agency that I worked for in New York was relatively high volume. I think the issue there is it just never stops, right? You know, in low to moderate volume systems, you can have a call and then you can have a lull after that. And even if you're starting to see the symptomology here of that cumulative stress, which we'll touch on here in a minute, you do have some downtime. For some people it's good, for some people it's bad. I think if it's your obligation to keep the lights on and the wheels moving and the provider's going at a 40, 50, 60, 70,000 annual call volume system, then that absolutely plays a role, especially in the management side of the coin. You know, your phone's never off, you never get that chance to decompress and take any of that away.
One of our viewers is asking about the terminology of CSD. There are terms we use to describe this that are more of a diagnosis, PTSD being one. We describe the incident as an operational stress injury. So their question is CSD considered a diagnosis?
That's a great question, John. So according to the DSM-5, which is the most recent revision that we currently have, circa October 2017, the symptomology of cumulative stress disorder would fall under the blanket of trauma and stressor-related disorders. So that more specifically falls under symptomology for PTSD. Operational stress injury definitely plays a role there, but as far as formal diagnoses in the DSM-5, that's under the umbrella of trauma and stressor-related disorders. Okay,
and then we have a question here about seeking help, and you touched on this quite a bit in your talk, but this reader wants to know, or this viewer wants to know, is it better to have people from within the agency help each other or an outside source only? Are people more likely to open up to someone who they don't work with and who doesn't have any idea about the problem?
I really think it's fielder's choice. You know, I think we've found a lot of good support can come within your peer network. You know, the people that understand the call you are on, that understand the stressors of day-to-day, that hold the same credentials, that work with you day in, day out. You can get a lot of good, positive support from that peer group. And full disclosure, I run a peer support team, right? So I certainly have a tremendous amount of buy-in on the efficacy of trained peers helping individuals in crisis and even through the day-to-day. But that certainly isn't to discredit an individual that wants to speak to someone completely unrelated. I genuinely feel that a marriage of the two is often best. I think that knowing that you have a team within your network and within your agency that helps take some of the stigma away, that gives you that space to talk, can help kind of take the boil away, right? You're no longer spilling over in the pot. You're kind of at a more manageable level, and that can help more long term. So I think that the short answer is it's a good combination of both, but I absolutely think that if you're leery to go to some stranger, I can tell you that the first time I talked about a pediatric cardiac arrest in therapy with just Jane Q therapist, she needed me to explain what an interosseous infusion was, and when I explained to her what an interosseous infusion was, she threw up in her coffee cup. So that's not a critique against the outlying therapist, but that's more playing to the you have to find the therapist that works best for you. So a good, healthy combination of both, in my opinion.
Here's a question about employee orientation and stigma. Do you think that if organizations were pushed to cover mental health distress in an orientation, this might help minimize the stigma? And they're asking about going beyond merely giving out an EAP assistance number to employees. Do you think that could help?
Abso-friggin-lutely. 110%. The easiest way to destigmatize this is to bring it up on the first day, right? If you're a brand new clinician or brand new to that agency and you're trying to be tough and you're trying to be serious and you want everyone to know that you have your stuff together and you can do your job well, if a preceptor, a member of management, or someone in a leadership or authority role, not specifically authority, but even in the realm of us as providers, my preceptor, my senior partner, what have you, talks to me about mental health and seeking help and letting us know what you need if you need anything, to take that away on day 1 or 2 or 3 is so tremendously important. If I had it my way, it would be a mandatory part of the curriculum, and then it would be a mandatory part of everyone's orientation in their agencies.
Okay, this kind of a different way of asking a question that we touched on earlier about the profile of EMS responders. To what extent does public perception and standards to which they hold first responders influence help-seeking behavior? People don't like to think that their healthcare provider can go through a tough time, and as a kind of a part 2 of that, everyone seems interested in the types of calls that first responders are dispatched to, but aren't quite ready to recognize that EMS providers are also human. So just another comment / question about the role of protector and the standards that first responders are held to.
You know, that's a phenomenal question to ask. When I talk about this, as I do all the time, and I talk to people that aren't in EMS, first response, or any form of civil service, and I say, you know that a first responder commits suicide every 4 days in America? They fall out of their chair. I have no idea, but you see this stuff every day. And I said, exactly. We see this stuff every single day. Every day we see stuff like this. And it really works to the point of us kind of breaking free from that stigma of, I can't be this protector, this helper, this white knight if I go see therapy. You're absolutely right. Steve Barry put a wonderful comic up in memory of a friend of his who recently took their own lives, where one provider is literally retuning the robotic back of another provider as families grieving over a call. You know, it certainly isn't. I genuinely think that it's not as stigmatized as we think it is. I think that our perception in the world is that we're these superhuman healers, but when we take a minute and say, you know, that's just as hard, if not harder on us as it is on the everyday Jack and Jill, I genuinely think that just makes us appear more human and doesn't take away from our quality as healthcare providers.
We have quite a few questions coming in about taking that first step. Tyler asks, what are some techniques to approach a crew member who you think might need help? How do you break the ice?
Certainly depends on how close you are with that provider. You know, I have colleagues in every job I've ever worked in that I consider family. They can talk to me very differently than John from the night shift, right? That guy that I kind of know, and I mean, I don't dislike or not particularly get along with, but, you know, whatever here or there. I think the biggest chunk of it is to be as calm and non-accusatory as possible, and appreciate that since we're talking about this now and we're getting all of this great feedback and talk about stigma, if that person responds to you poorly, please don't take offense to that. If you say, hey, that call was pretty crazy, do you need anything? You know, it looks like you've been on edge lately, this, that, and the other, and they tell you to go somewhere and do something, that's okay, right? You can take a deep breath and say, well, if you ever need anything, you have my cell, or if you don't, here's my cell. And start very gently broaching into that conversation. Obviously, if you feel that someone's well-being or safety is an imminent threat, then that's a very different discussion. But just on the whole of kind of how do I bring this up to my team, if you're very close with them, I'd say just bring it up. If you're not very close, bring it up and be ready for a little bit of pushback and just be as non-judgmental and unapprehensive with that as possible.
And that conversation probably will be easier to have in an organization that has that culture of support. So Emily wants to know, how do you approach a peer or a subordinate in an organization that has done nothing to prevent or even address critical incident stress? I guess
you get to start it.
Right. Yeah, if the organization is not, if you don't have that organizational support behind you, are there some strategies that you can identify?
And John, just to clarify, is that kind of a system-wide approach, or is that how you'd interact with one individual?
I think the question is, you know, if you're approaching a colleague and you don't have that culture from the organization, you don't have that support or those resources to point to, it's really more of a one-on-one conversation. Are there you know, differences to that conversation versus being in a company that really does have the support system in place?
Okay, thank you for clarifying. I just wanted to make sure I'm answering that right. So hopefully put people at ease.
Go ahead.
I really hope that people understand that whether you have a long-standing policy in place and your management, your superiors recognize it or not, the peer-to-peer interaction really doesn't change much. You know, in most peer support teams, the managerial chunk of peer support is way towards the bottom. Right? This is not something that we institute in the very beginning. So as far as reaching out to a colleague and seeing if you can be of any assistance or how you can help them get help if they or you feel that that's necessary, there isn't much change to that approach regardless of whether there's an instituted policy in place or not.
Another question here about management. Jessica wants to know, how does going to management affect how they will look at you as a provider when you are claiming mental health fatigue?
And all we can do is hope that these are actually managers asking these questions, because that would be great to get this understanding from all aspects of this. I certainly can't speak on behalf of every manager. I can tell you that in most employee assistance programs, that kind of cursed 1-800 number that we get at the end of the emails for bad calls, when you reach out to them, if you see them and they ask you to interact with them or whatnot, your employer can at most find out if you attended or not. And if there's an issue where someone genuinely feels as though you're unfit for duty and are worried about your well-being to go back to work, that has to be clarified to you. And in the event that you're ever interacting with a therapist or a counselor and you have questions about that, I 110% advocate that you do so you know what information is and isn't being disseminated to your management team. Now, as far as the stigmata associated with that, my best advice is when you go get that help and you start to make your way out of this trench and out of this trouble, come to work the best, most put together employee you can be. Show up on time, boot shined, uniform together. You know, don't give them a reason to perpetuate a stigma if it's there. I genuinely hope that it's not, and hopefully with all of this outreach we can say, We understand this is a thing. This is no different than treating a physical injury. We do it, we manage it, we support you, and then you're back to work. No different than if you hurt your back. But in the event that that stigmata still exists in some instances, do your best to be the best clinician you can be while you're seeking that treatment as you're going to work. It's the best way to help reduce that stigma.
And what if you meet resistance when you're approaching a colleague who you think might be showing some signs? Houston asks the question, how do you get help for a coworker who might not want that help?
You can't really, and I think that's a really important part of this to clarify is we can't force upon this to anyone. The only exception being someone who we feel is an imminent threat to themselves or is in some other way, shape, or form not safe. But as far as somebody who thinks this is all hogwash and you can't stand the heat, get out of the kitchen, and Chiefs don't cry, and all that other nonsense, it really is just genuine empathetic support over time. I can honestly tell you that as the guy who's been the hugger in my department through a number of departments, not everybody hugs back, right? Some people say, you can go scratch, and I'm totally fine, and everything's fine, and away they go. And a couple days later, hey man, how you doing? And it continues on like that. The only advice I can give you as you're trying to do this is, as we talk about stigma, that clinician who you think might need some help and you reach out and you get bad pushback, please don't treat them like a leper, right? Keep treating them like paramedic John or paramedic Amanda, right? They're the same person. If they give you some pushback, some of that is vulnerability, right? Some of that is the stuff that we talked about in the early aspects of this presentation. So by all means, keep your eyes and ears open. And if you feel that there's a change from not okay to imminent threat to self and well-being, then that's a very different approach. But if not, just keep being you and keep reaching out and do so as kind and empathetically as possible. And it really is the best way to work through people that may take some time to really adopt into this.
You touched on establishing a peer support team. Julian wants to know, do you have any advice for anyone who is starting or running an in-house peer support team?
If any members of my peer support team are here, I'll say patience is absolutely number one. It takes a long time for stuff like this to go into fruition and to make these teams. And the other humongous chunk of peer support, and what I genuinely think is the biggest thing that will ensure this fails, is any lack of confidentiality. So you need to have that discussion with people that are either in your peer support team now or are thinking about being in your peer support team in the future. Confidentiality has to be the end-all be-all. My partners, my teammates, my colleagues need to know that if they come to me, they're only coming to me. Right? My team and I may communicate very, very briefly, but it's not leaving that bubble of the peer support team. And one of the best pieces of advice I can give you as I too work through the navigation of a new peer support team is ensuring that people are really bought in and really want to do this for the right reasons, and being absolutely ironclad on the fact that what is said to the peer support team doesn't leave the peer support team.
Very interesting question came in from Susan about asking about returning to work. What's the best way to determine how and when to return to work after therapy, or to even make the decision to change careers? How do you know? And she wants to know how long does this process take?
That's a really good question, and unfortunately, I'm not going to be able to answer it. That is so individualized for each person and their counseling team, their peer support team, the people that they're relying upon and they're talking to. I'd say that if you're at that stage where you cannot go to work until you've undergone some type of counseling, therapy, what have you, and I don't mean taking a mental health day, I mean off the schedule for a substantial period of time because of some underlying complication that you have or some tremendous buildup that you have, I would not force a timeline upon you. I know that some employers need timelines for all of their HR things, and I appreciate that, but I would ask you to not force a timeline on yourself and keep those honest, genuine questions alive when you're talking to your counselor or your support team.
Okay, and from Michael, we have a question about other healthcare providers. How does CSD for EMS providers compare with CSD experienced by nurses, physicians, et cetera? Why do we separate these groups when addressing this problem?
You know, I think this could very easily be covered in an umbrella of any member of a healthcare team. I certainly don't think that paramedic CSD is different than nurse CSD. I think our triggers might be different. I think our reasoning behind what's stressing us out might be different. But I wouldn't believe for a second that the nurse or the EM physician at the hospital I go to 22 times a day would have any lower propensity to this as any other first responder would. I think the biggest reason that we put a heavy first responder feel to this is because I am one, so I feel it's the avenue that I have the most street cred to talk about, and I think that conversely, it's also the avenue where it's the least acceptable. You know, oftentimes you'll have a bad incident, and while I'm not encouraging or discouraging any type of CISD or critical incident stress debriefing, you know, the hospital will have the debriefing and the paramedics won't be invited, or the EMS providers won't be invited, or invited in a very tertiary sense, kind of as a last minute afterthought. So I think it's important to certainly not exclude anyone from the stuff that we're talking about today. This was primarily my focus because it's what I do.
Do you have any thoughts on alternative treatments? Milton wants to know, how useful are alternative modalities such as Reiki in dealing with stress?
You know, like we talked about when we talked about self-care. So self-care can be a number of different things to a number of different people. I don't like to acknowledge that I meditate. I had always, for years and years and years, viewed meditation as little symbols and, you know, bells ringing in the corner, and it had to be this incredibly formalized sit on a pillow kind of process. And my meditation now can be 10 minutes at the end of my day or 10 minutes in my bunk room at work. So I think that whatever alternative modality you find, Reiki, I know some people even look at like chiropractic therapy and swimming and exercise and all of that. I think that those are all fantastic means to just kind of keep your barometer in check, right? Am I healthy? Am I hydrated? Am I fed? All of those things, and however you get to that junction is totally fine.
This is kind of a running thread through the conversation today, but Christopher is asking, if this is such a big problem, why are we not doing more about it in the EMT to paramedic certification classes? Why is there not more attention paid to it in that curriculum?
I think, Chris, you're getting there. If you look at an EMT book from 10 years ago, your health and wellness section told you to lift with a straight back, right? And now you look at the most recent EMT paramedic critical care curriculums, and now we've grown to a page and a half, right, about eating well and staying hydrated and understanding that calls can take a toll on us. So I think that the relative leap is huge, even though as we look at it now, it's still 2 pages in a 2,000-page textbook. And unfortunately, as we talk about the stigmata, who in your paramedic or EMT academy was going to talk about this, right? I'm very fortunate. I come from a group of people that can have this uncomfortable and awkward conversation. But if your paramedic academy or EMT academy doesn't have that, then there may not be someone there that's willing to have that talk.
We have another one here about a large system from Manfred. How do you prevent cumulative stress disorder in an EMS service with approximately 420 people? And is there any difference?
It's a great question.
Between sides of it?
Sure. I mean, if you have a 16-member peer support team and a 50-member organization, the math there is pretty easy, right? I think the onus on the larger departments is on the clinician. And I'm sure that if you're in a 420 employee agency, you've been hearing that from everything to equipment to ambulance checks and everything in between. But the onus then is on you to make sure that you're looking after yourself, your partner, your team, making sure that each individual house, right, South Station, North Station, I'm making generalizations here, are all keeping tabs on one another and just keeping that eyes out. Because, well, in one phrase you can say, oh my God, 420 people, that's tremendous. On the opposite side of the coin, you could say, hey, 420 people who all keep their eyes and ears open to one another could be a tremendous team. So I certainly don't think it will be the easiest thing in the world, but as we start to break down the stigma and talk about it clinician to clinician, large agencies to small agencies won't matter too much.
This is interesting from Nancy. Is there a difference between CSD and the more known term burnout? And if they are different, what are the differences between CSD and just quote unquote burnout?
That's a great question, and we're kind of veering outside of what the DSM defines for terms, so bear with me, because you won't be able to look this up in the DSM, but as I appreciate burnout, and as I talk to other clinicians about burnout is the end of this, right? Burnout is I've suffered cumulative stress for so long that I can no longer come to work. Right now, I have no other option but to find a career. I have no other option to do this. So I really think that all we're doing when we differentiate burnout versus cumulative stress disorder is just talk about time and the process and where we are as far as what we can do to get ourselves out of it. I still think that burnout is something you can come back from. I argue that I was burned out when I left my private, high volume private agency to go to college, and didn't appreciate I was burned out until I had a couple months off and said, oh my God, I don't hate the world anymore. So I think that in sense of terminology that we're just talking about the end rather than the beginning or the middle.
We've had a couple questions come in about whether workload is related to this. Does shift work contribute to it? Overtime, switching between days and nights, not enough time off. Or do you have any thoughts there as far as the amount of work and some of these problems manifesting themselves? Could some time off help?
Absolutely, and I believe this is from my friends at Southern Maine Community College. I think that the struggle with shift work is really in being able to manage your self-care. I think that the self-care gets harder as you move from day, night, day, night, day, day, night, day, reverse 24, back and forth. But as far as the propensity of all of the other aspects, I genuinely don't think that shift work would change in any way, shape, or form. But it definitely makes the self-care, you have to be a bit more intentional to ensure that your self-care is in place.
We've also had several questions come in relating to dispatchers. I'll read this one from Bonnie. Do you think that private agency dispatchers could also benefit from getting help, especially if they can sometimes take out their anger on their crews, which in turn causes additional stress for field providers? Do you think that dispatchers could also benefit? And if so, what would be the best way to address this concern among dispatchers?
Absolutely is the short answer, and I think that it's important to remember that vicarious trauma or the trauma from being involved in an incident but from a distance is just as real. I always said that the hardest part of being a dispatcher had to be hanging up the phone and then not knowing what else is going on, right? The ambulance shows up, the comm specialist hangs up the phone and then does the other 45 things that they have to do to make sure that we're being safe and that we're looked after and all of this. So again, as far as stigmata is concerned, don't bully the comm specialist or the dispatcher who's upset over a call. I think it's completely appropriate for the person taking the phone call, for, just to give an example out there, right, the hysterical mom that calls a comm specialist because their child is drowned. You can't convince me that that call is any less stressful for the comm specialist or the dispatcher than the paramedics, EMTs, police, and fire that are going to that call and resuscitating that child. So I think the biggest chunk there, to answer the question, would just be to help alleviating that stigma and including them in that circle as well, as far as absolutely a stressor that can wear you down over time, and then here are the ways that we can help mitigate that.
This is kind of related to a question we had earlier. I'm going to read this one from John. Do you think a peer support group within your own agency is likely to be more open and comfortable than a conversation with a total stranger to someone reaching out for help? Do you have any preferences on which would be more productive?
So I don't know if I can stake my claim as to which is more productive. I personally feel that going to peers is an easier and safer alternative. But I certainly know plenty of individuals that are very willing to get help but don't want to talk to their peers. I also think we're going to see this improve as we continue to chip away at this stigma. Because when I talk to providers who don't want to talk to their peers, it's all rooted in stigma. I'm the senior medic. I can't let anybody know that that call upset me. They rely on me. I'm the preceptor. I'm this and that and the other thing. I really think that if we start to break down the stigma, then the peer support will seem less scary to those people that are wishing to avoid it. But I genuinely think that peer support is an excellent first step to be used, and in some cases to be used in conjunction with more formal counseling or therapy.
Okay, we're up against the top of the hour. I'm going to, first off, we've gotten a lot of comments, James, on just people thanking you for this presentation. I'm going to read this comment quickly from Erica. I don't really have a question. I just wanted to thank you for the presentation. I now understand what I've been experiencing and that I can and should seek help. So thank you for that. Thank you for all the comments that came in that were very similar to that. You've definitely helped a lot of people today. And I'm going to end with kind of an overall question that we can wrap up with from Katie. What's the one piece of advice that you would give responder families and significant others for dealing with people who have CSD?
First, I'll say thank you to Erica. I really appreciate that, and thank you to everyone who put such positive comments in there. That's tremendously helpful as I continue on doing this. As far as advice for providers, family, etc., from Katie, the easiest answer, and I feel like I'm a broken record now, but it's really, really important. We are not robots. No one expects us to come to work at 6 a.m. every day, do our job flawlessly, and go home, right? Except the problem is a lot of people expect us to do our job flawlessly and go home every day, regardless of what we see. If we remember that we have needs, if we remember that it is not only okay but expected that we need rest, that we need sleep, that we need to stay hydrated, we need to stay fed, and occasionally we need to talk to our peers or a counselor or a therapist. If we help normalize that, it gets better. Don't ever be afraid to talk to your families or loved ones. That there's been study after study that shows that is nowhere near as jarring as we used to think it was. We used to never talk to our families because we didn't want to harm them or scar them in any way. We know that that isn't the case when we reach out to our family and loved ones. And simply just keep your eyes out and your ears open. You know, if it looks like someone's having a bad day, they probably are. And just because we put on a flight suit or a uniform or a helmet every day when we go into work does not mean that we are in any way, shape, or form exempt from any of this.
All right, I'm going to tack on one more from Michael. If you could change one thing about our EMS system that would better support its own providers dealing with cumulative stress, what would that be?
If I could change one thing, I would start at the very beginning. I would have this lecture or talks like this in my EMT and paramedic academies. Start this discussion now so our newest know how okay this is. Keep this discussion going in agencies, because I genuinely think if we break down the stigma behind needing help, getting the help is straightforward and is easy for us to see.
Okay, we're over our time. We're going to wrap up for today. James, thanks again for all your time again. And we'd also like to thank Distance CME for sponsoring today's presentation. One final note to the audience, we will have this program available for viewing online within the next several days. You can find that at www.emsworld.com/webinars. Thanks again to all our attendees. James, thank you once again for your presentation today, and have a great rest of the day.
Yes, thank you very much. And just to dovetail on John real quick, I am more than happy to continue any of these discussions outside of this webinar. EMS World and Distance CME will have contact info of mine up. So if anyone wants to continue this talk, please don't hesitate to do so.
Okay. Thanks again, James, and talk to you soon.
Thank you.